Let's move on to the next section about the classification of the UI. The first distinction is between transient and persistent UI. The transient UI has a sudden onset and is usually caused by an acute illness or a reversible factor. The key point is that it usually improves or resolves once the underlying cause is identified and treated. To help remember the common reversible causes, we use the mnemonic diapers, which we will go through on the next slide. In contrast, persistent UI is a chronic condition that persists over time and reflects an underlying abnormality of the lower urinary tract, the nervous system, or the patient's functional status. Persistent UI can be classified into 5 major types: straight UI, erg UI, mixed UI which combines straight and erg symptoms, overflow UI, and functional UI, what we will look in more detail after. For transient UI, let's go through the mnemonics of diapers. D is for delirium, which an acute confusional state can itself cause incontinence. I is for infection, specifically urinary tract infection. A is for atopic vaginitis. The first P is for pharmacological causes that many medications can precipitate incontinence that we will look after in the table. The second P is for psychological causes such as depression. E stands for excessive urine output. It maybe come from hyperglycemia, hypercalcemia, diuretics, or excessive food intake like caffeine, alcohol, or some disease that have volume overload or complication of peripheral edema. R is for restrict mobility, that an impaired ability or even unwillingness to reach a toilet in time. And S is for stool infection because of full rectum can mechanically and neurologically disrupt bladder function. Therefore, the key clinical point with transient UI is that these are reversible causes. Please identify them and treat them, and the incontinence often resolved without ever needing to reach for a bladder-specific medication. Let's focus on medication, which are one of the common reversible causes of transient UI. You can see several examples in this table. Some medication increase urine production and therefore increase urinary frequency or urgency. Common examples are diuretics as well as alcohol, and which act as diuretics. Other medications interfere with the normal micturition pathway that we reviewed earlier. For example, anticholinergic drugs, which is inhibit acetylcholine at the M3 muscarinic receptors. When acetylcholine is essential for parasympathetic mediated detrusor contraction during the voiding phase. Blocking this can impair bladder emptying, leading to urinary retention or overflow incontinence. Similarly, alpha-adrenergic agonists, this one, increase bladder outlet resistance by contracting the bladder neck and proximal urethra. This can also result in urinary retention and overflow UI. And in contrast, alpha-adrenergic blockers relax the bladder neck, reducing outlet resistance and facilitating the bladder emptying. That's why they are commonly used to treat bladder outlet obstruction due to benign prostatic hyperplasia. Moving on to the subtype of persistent UI, let's start with straight UI. The underlying mechanism is inadequate sphincter closure during the periods of increased intra-abdominal pressure. In other words, whenever the pressure inside the bladder exceeds the urethral closure pressure, urine leaks. Typical triggers are anything that increases intra-abdominal pressure, such as coughing, sneezing, laughing, exercising, lifting heavy objects, or other activity that strain the abdomen. Chronic conditions that repeatedly increase intra-abdominal pressure, including obesity and chronic constipation, also increase the risk. Clinically, patients typically report a small amount of urine leakage immediately during these activities without a preceding sensation of urgency. This history alone often strongly suggests straight UI. The underlying problem is weakness of the urethral closure mechanism. This may result from pelvic floor muscle weakness leading to urethral hypermobility, or from intrinsic sphincter deficiency, in which the urethral sphincter itself is unable to maintain adequate closure pressure. Straight UI is much more common in women because the major risk factors include pregnancy, vaginal delivery, menopause, and estrogen deficiency, all of which weaken pelvic floor support and reduce urethral closure. In men, straight UI most commonly occur after radical prostatectomy, where injury to the external urethral sphincter or its supporting structures reduce urethral closure pressure. So the key clinical features are leakage with increased intra-abdominal pressure, a small volume of urine loss, and no preceding urgency. Next is ERK UI, which is actually the most common form in older people. The underlying mechanism is increased detrusor hyperactivity. In other words, the bladder contracts involuntarily during the storage phase, before it has reached an appropriate volume for voiding. As a result, the bladder is unable to store urine properly and the intravesical pressure rises above the urethral closure pressure, leading to urine leakage. This detrusor overactivity may occur idiopathically, but it is also commonly associated with neurological disorders such as stroke, dementia, Parkinsonism, multiple sclerosis, or spinal cord injury. In addition, local bladder conditions including UTI, bladder stone, reticular tumor may irritate the bladder and trigger involuntary detrusor contractions. Clinically, patients describe a strong, sudden desire to void, and when they leak, it usually a laugh about happening right as that ERK hits. It's quite different from straight UI because this ERK UI, you leak when you desire to void, so the volume usually laugh, but the straight UI is accompanied by the increased intra-abdominal pressure. So the leakage amount usually small amount. Okay, before we move on, I'd like to briefly mention overactive bladder. Because it's closely related to ERK UI, overactive bladder is not the same as UI. It is a symptom syndrome characterized by urinary urgency, usually accompanied by frequency and nocturia, with or without urgency UI. In other words, not all patients with overactive bladder have urinary leakage, but patients with ERK UI usually have overactive bladder symptoms. The next one is overflow UI. Overflow UI is essentially the opposite problem. Is an inability to void completely because of insufficient bladder contraction or bladder outlet obstruction, or both. On the contraction side, we have decreased detrusor contraction or an contractile bladder from neurogenic causes, such as diabetic neuropathic bladder, low spinal cord injury, or detrusor sphincter dyssynergia associated with multiple sclerosis. On the obstruction side, we have anatomical causes like prostate enlargement, uterine stricture, or pelvic prolapse. Both mechanisms eventually lead to chronic bladder overdistension because the bladder cannot empty completely. Residual urine gradually accumulates until the bladder becomes overfilled. Once the pressure inside the bladder exceeds the outlet resistance, urine leaks out as overflow incontinence. Clinically, patients usually describe continuous dripping or small volume leakage rather than sudden episodes of incontinence. It's also important to distinguish acute from chronic urinary retention. Acute urinary retention presents with a painful, distended bladder and complete inability to void. In contrast, chronic urinary retention develops gradually. Patients are often painless despite having a markedly enlarged bladder, and paradoxically, they may present with overflow UI because the bladder has become chronically overdistended. Finally, let's look at functional UI. This type is quite different from the others because the lower urinary tract itself may be functioning normally. In other words, there is no intrinsic problem with the bladder or ureter. Instead, the patient is unable to reach the toilet in time despite having a normal desire to void. Common contributing factors include cognitive impairment, impaired mobility, psychological unwillingness, and environmental barriers such as a toilet that is too far away, poor lighting, or clothing that is difficult to remove. This should remind you of the continence model we discussed earlier. Continence depends not only on a normal lower urinary tract, but also on intact cognition, adequate mobility, and an appropriate environment. When any of these factors are impaired, functional UI can occur even though the bladder itself is normal. This is an important subtype to recognize because the management is usually non-pharmacological. Instead of prescribing medication, interventions such as improving the environment, providing a bedside commode, optimizing mobility, or implementing a scheduled toileting program are often much more effective. So let's move to the next section about the clinical assessment. First of all, started with history taking. The most important question is what type of urinary incontinence does this patient have? Because once you identify the subtype, the underlying cause and management often become much clearer. Start by characterizing the leakage. Ask about when it started, how long it had been present, whether it had been getting worse, how often it occurs, and approximately how much urine is leaked each time. Then look for the characteristic pattern of symptoms. Leakage during coughing, sneezing, laughing, or physical exertion suggests stress UI. Leakage that is preceded by a sudden, compelling urge to void suggests urge UI. Continuous dipping or persistent small volume leakage, raising suspicious for overflow UI. And if the patient reports being unable to reach the toilet in time, particularly because of impaired mobility, cognitive impairment, or environmental barriers, think about functional UI. In many cases, a careful history alone can strongly suggest the diagnosis, even before you perform the physical examination or order any investigations. Once we identify the type, the next question is what is causing it? First, please look for reversible causes. You may use the diabetes mnemonics. Ask about acute confusion, symptoms of UTI, vaginal atrophy, recent medical changes, depression, excessive urine production, mobility problems, and constipation. Many older adults improve simply by identifying and treating these reversible causes. Second, assess about the lower urinary tract symptoms. The lower urinary tract symptoms divided into storage symptom and voiding symptom. These symptoms provide important clues to the underlying pathology. For example, storage symptom including of frequency, urgency, nocturia. If they have a problem with storage symptom like they cannot store the urine, the pathology suggestion of overactive bladder or urge UI. Whereas voiding symptom raise suspicion for bladder outlet obstruction or impaired detrusor contractility because they cannot void properly, which may lead to urinary retention and overflow UI. Finally, don't forget to look for red flags, including persistent hematuria, recurrent UTI, pelvic mass, large prolapse, marks enlarged prostate, or suspicion of prostate cancer, previous surgery, previous radiotherapy at this area, or the sign or symptom of neurological disease, because this may indicate a more serious underlying condition is quite complex and maybe have some hidden serious underlying causes. If any of these red flags are present, the patient requires further evaluation or referral to an appropriate specialist. Beyond the incontinence history itself, we also need to perform a comprehensive assessment. First, review the patient's medical and surgical history. Pay particular attention to multi-mobility, medications, previous pelvic or lower urinary tract surgery, prostate surgery in men, and any history of pelvic radiotherapy, as this may contribute to urinary incontinence. Next, assess the severity and impact of the symptoms. Ask how often the patient leaks urine, how many pads they use each day, whether incontinence limits daily activities or disturbs sleep, and how much it affects their quality of life. This helps us understand not only the severity of the condition but also whether treatment is making a meaningful difference. Because we're caring for older adults, a comprehensive geriatric assessment is essential. Urinary incontinence is rarely an isolated problem in older adults. Comprehensive geriatric assessment helps identify geriatric syndromes and other contributing factors that may both cause UI and be worsened by it, including falls, impaired mobility, functional dependence, cognitive impairment, depression, constipation, polypharmacy, and multi-mobility. By identifying these reversible or modifying factors, CGA or Comprehensive Geriatric Assessment allows us to develop a personalized, multidisciplinary management plan that improves not only continence but also overall function, independence, and quality of life. Finally, always clarify the goals of care. Ask what matters most to the patient and caregiver. Some patients may hope to become completely continent, while others simply want to reduce nighttime leakage, improve sleep, or lessen caregiver burden. Our treatment plan should always be individualized according to the patient's or caregiver goals. The physical examination should be targeted based on the suspected underlying causes rather than performed routinely in every patient. Start with a general examination including weight, height, BMI, as obesity is a risk factor for stress UI. An abdominal examination should be performed looking for tenderness, mass, palpable bladder. A markedly distended bladder suggests significant urinary retention and possible overflow UI. A genital examination is indicated when pelvic pathology is suspected to look for pelvic organ prolapse, vaginal or urethral atrophy, or a pelvic mass. A digital rectal examination should be performed when clinically indicated, particularly if fecal impaction. It allows assessment of sphincter tone, fecal impaction, rectal mass, and inment the size and consistency of the prostate. A focused neurological examination should be performed when neurological disease is suspected, assessing lower limb neurological function, gait, mobility, and cognition. Overall, the physical examination should be guided by the history and the suspected subtype of UI. As with the physical examination, investigations should be guided by the clinical history and examination findings rather than ordered routinely for every patient. Basic laboratory tests may include urinalysis and urine culture when UTI or hematuria is suspected. Serum glucose when diabetes or hyperglycemia is suspected, as polyuria can contribute to UI. Renal function and electrolytes when renal impairment or metabolic abnormalities are suspected, particularly before initiating certain treatments. Serum calcium when hypercalcemia is suspected, as it can cause polyuria and worsen urinary symptoms. Sorry for my tongue tie. Further investigation should be performed when clinically indicated. These include post-wall residual measurement, ultrasonography, urodynamic studies, CT, MRI, and cystoscope. Post-wall residual urine is the investigation that measures the amount of urine remaining in the bladder immediately after voiding, usually using a bladder ultrasound scanner. It should be measured whenever urinary retention is suspected. Post-void residual urine greater than 200 milliliters is generally considered abnormal and suggests impaired bladder emptying or bladder outlet obstruction. Ultrasound used when structural abnormalities suspicious, such as hydronephrosis, bladder stone, or high post-void residue are suspected. For urodynamic study, evaluate how the bladder store and empty urine. The procedure is composed of a small catheter is inserted into the bladder to measure pressure while the bladder is filled and then empty. This helps identify the underlying mechanism of urinary dysfunction. So the test is reserved for selected patients when the diagnosis is unclear or before invasive treatment. The imaging of CT or MRI when we suspected of malignancy, upper urinary tract disease, or neurological pathology. The last one, cystoscope, when there is hematuria or recurrent UTI because we suspected of bladder pathology. Another simple but very useful tool is the bladder diary. Patients are asked to record fluid intakes, voiding times and volumes, episode of urinary leakage, urgency, and pad use and nighttime voiding. Record at least 3 days. It helps us identify the pattern and severity of urinary symptoms, distinguish different types of UI, monitor treatment response, and engage patients in their own care. More detail about the bladder diary because it is the useful tool and not invasive. Patients are asked to record their fluid intakes, voiding times, and volume, episodes of urgency or urinary leakage, and nighttime voiding. A bladder diary helps us identify the patient voiding pattern and guides both diagnosis and treatment. There are 4 key pieces of information we look for. First, the input and output balance, which tells us whether excessive fluid intake or polyuria may be contributing to the symptoms. Second, daytime voiding frequency to identify urinary frequency. Third, nocturia, including how many times the patient wakes to void overnight. And finally, the functional bladder capacity, which is estimated from the largest void volume. Small void volume may suggest detrusor overactivities or bladder hypersensitivity. In addition, the timing of urgency and leakage episodes often helps us distinguish different types of UI and provides a useful baseline for monitoring treatment response. Yeah, finally, we are in the last section of the UI. Okay, move on to the management, starting with the foundation of treatment. Lifestyle intervention. This should be recommended for almost every patient regardless of the type of UI. Okay, first one is reduce urine production, which is the encourage patients to optimize rather than simply restrict their fluid intake, and advise them to limit caffeine and alcohol because both of them can increase urine production and irritate the bladder. The next one, reduce bladder stress by encourage weight reduction in patients with overweight or obese patient, and smoking cessation because it can cause chronic coughing, which can increase intra-abdominal pressure and worsen the stress UI. The next one, improve toileting. Make it easier for patients to reach the toilet by reducing environmental barrier and improving toilet accessibility. The last one, don't forget to prevent and treat constipation, as constipation can worsen UI by increasing pelvic floor strain and compressing the bladder. Although this intervention may seem simple, but they often have a meaningful impact on symptoms and should always be the first step before considering pharmacological treatment. Okay, after lifestyle modification, the next step is to choose treatment based on the type of the UI. So look into the table. For straight UI, the first line is pelvic floor muscle training. Because if you can remember, the mechanism or the pathology of the straight UI is happen because the inadequacy of urethral closure. So improve this, strengthening the pelvic floor muscle can improve the symptoms. Okay, but if conservative treatment fails, selected patient may benefit from procedures such as periurethral injection or surgery. Okay, the next one for the ERG UI, bladder training is the cornerstone of treatment. If symptoms persist, so consider the pharmacological treatment. In women with genitourinary symptoms of menopause, topical vaginal estrogen may help improve symptoms. Okay. For functional UI, okay, treatment should focus on the underlying function problems rather than the bladder itself. This may include caregiver support, scheduled toileting, environmental modification, and appropriate continence products when needed. Finally, if the patient has a high post-war residual or urinary retention, the priority is to relieve the obstruction or improve bladder emptying. Depending on the cause, this may involve treating bladder outlet obstruction, removal, intermittent catheterization, intervalling catheterization in selected patient. So the key method is simple. Always identify the subtype first, because each type of UI has a different treatment strategy. Behavioral therapy is the cornerstone of treatment for straight, erg, and mixed UI, and it should generally be tried before pharmacological therapy. There are three main behavioral interventions. The first one is bladder training, which is particularly effective for erg UI. The aim is to increase functional bladder capacity, improve voluntary bladder control, and suppress involuntary detrusor contraction. Patients are encouraged to gradually delay voiding by extending the interval between bathroom visits over time. The second one is pelvic floor muscle training. The goal is to strengthen the pelvic floor and ureteral support and increase ureteral closure pressure. Patients should learn to contract the pelvic floor muscles in isolation without tightening the abdomen, buttocks, or any other muscles. Like any muscle strengthening exercise, this behavioral therapy need regular practice over several months for significant improvement. The last one is scheduled toileting. This is especially useful for patients with cognitive impairment or dementia who may be unable to participate in bladder training. Caregivers assist the patient to the toilet at regular intervals, typically every 2 to 3 hours during the day, regardless of whether the patient reports the urge to void. The key message is that behavioral therapy is effective, safe, and free from medication-related adverse effects. Although improvement takes time and requires patient motivation or caregiver support, it remains the first-line treatment for most older adults with UI. When lifestyle modification and behavioral therapy are not enough, pharmacological treatment can be considered. The choice of medication depends on underlying subtype of UI. First, about erg UI. The goal, we need to relax the bladder or decrease the detrusor activity. So the main drug classes are anti-muscarinic and beta-3 adrenergic agonists. For anti-muscarinics, it works by blocking M3 receptor, so resulting in decreased detrusor contraction. These are the common agents of drug of this group. The second one is beta-3 adrenergic agonists, work through a different mechanism by relaxing the detrusor muscle. because it enhances the beta-3 receptor, so it makes the detusser muscle more relaxed. And during bladder filling, it increases the bladder capacity. For men with problem with bladder outlet obstruction due to benign prostatic hyperplasia, alpha-1 adrenergic blocker is considered for the symptom because it inhibits alpha-1 receptor, so it decreases the contraction of the urethra or the outlet. And in postmenopausal women with genitourinary syndrome of estrogen deficiency, topical vaginal estrogen may improve urinary symptoms associated with vaginal or urethral atrophy. When prescribing these medications in older adults, always consider their adverse effects. For antimuscarinic, commonly cause anticholinergic effects such as dry mouth, constipation, blurred vision, urinary retention, confusion, cognitive impairment, and it can increase risk of falls. The newer sulfurnacin may have less side effect of anticholinergic because it's more empty selection. For beta-3 adrenergic agonists, beware of high blood pressure because it may increase blood pressure. So, blood pressure should be monitored, particularly in patients with uncontrolled hypertension. Okay, the last slide of the UI. Let's summarize the key messages on UI. Urinary incontinence is common, but is not a normal consequence of aging. Aging reduces the functional reserve of the lower urinary tract, making older adults more susceptible to incontinence. Second, all older adults for UI often underreported. So, the screening is needed because the symptom significant impact on quality of life, function, and caregiver burden. The third, when approach the syndrome, always identify reversible causes and treat reversible factor whenever possible. The next one, management should focus on the underlying cause. Lifestyle modification and behavioral therapy remain the first line treatment for most patients, with medication reserved for selected patients according to the subtype of UI. Finally, a comprehensive jury assessment is essential. UI is rarely an isolated problem in older adults. Assessing mobility, cognition, medication, constipation, comorbidity, function, status, and the patient goals allow us to develop an individualized management plan that improve not only continence, but also overall function and quality of life. So far, we focus on bladder problem. Let's now move on to another very common genetic syndrome that is correlated to urinary incontinence, constipation.